Good day. I am Brian Hoffland, President of Research to Prevent Blindness. Welcome to RPB's Lunch and Learn Eye on Thyroid Eye Disease, or TED, as the acronym goes. Research to Prevent Blindness is the leading nonprofit organization supporting eye research directed at the prevention, treatment, or eradication of all diseases that damage and destroy sight. RPB was founded in 1960. And over our 64-year history, we have awarded more than $400 million in research grants to the most talented vision scientists at the nation's leading medical schools. As a result, RPB has been associated with nearly every major breakthrough to the underlying understanding and treatment of vision loss. In today's educational session, you will hear from an RPB-supported talented scientist, Dr. Fatemeh Rajaii, about thyroid eye disease, or TED, and its causes, impact, and current cutting-edge research. Dr. Rajaii received an RPB Physician Scientist Award for her research. You will also hear from Justine Peters, a working professional who has had TED for many years. I want to say thank you to all the generous supporters of RPB who make our work possible. I'd especially like to thank Amgen for their support of today's educational event. The importance of supporting medical research has never been so apparent. We thank you for your partnership to support innovative vision research and to ensure that new breakthroughs are possible. If you have not yet supported RPB, please consider doing so to help make sure that we are able to continue with these breakthroughs. Getting back to today's session, let me introduce our moderator. Margarita Ochoa-Maya, MD, is a Senior Medical Director of the Rare Disease Unit at Amgen. She is a board-certified endocrinologist and internal medicine physician. Across her career, she has worked in academia, private practice, industry, and clinical research, championing digital transformation in healthcare. Dr. Rajaii will introduce our two speakers for today and moderate the Q&A session at the end. I will serve as timekeeper for our event, and we want to make sure that we have time at the end for a robust Q&A session. Dr. Ochoa-Maya, take it away.
Thank you very much, Brian. I am happy to be here, quite honored to be speaking to the audience today. Our event today is on thyroid eye disease, which is associated with incredible burden, humanistic as well as financial burden with patients. And in that regard, thyroid eye disease is an autoimmune disease, usually associated with Graves' disease, which is a thyroid condition, but it also can be associated with other thyroid problems, but it's most likely associated with Graves' disease. TED, as we call it, thyroid eye disease, can also be called Graves' orbitopathy. It is a disorder that causes inflammation and swelling, as well as damage to the tissues around the eye, including the muscles, the fatty tissue, and the connective tissue. Today, we will talk about how thyroid eye disease impacts the structure of the eye and the body, as well as the patient as a whole. This topic is important because we believe that addressing thyroid eye disease can prevent vision loss. And the sooner we address it, the better it is. And so we strongly believe in the importance of education and awareness of all our stakeholders. And that includes patients and caregivers, providers, physicians, and pharmacies, everyone who needs to know a little bit about thyroid eye disease by creating awareness and then being able to then discuss the importance of medications that can be provided. These conditions are especially important to Amgen because we then do produce the medication Tepezza, which can address and treat thyroid eye disease. Now, I am pleased to introduce our first speaker, Dr. Fatemeh Rajaii. Dr. Rajaii is an assistant professor of ophthalmology at the Wilmer Eye Institute. She specializes in reconstructive and cosmetic eyelids, orbital, and facial surgery. This includes the surgical treatment of eyelid malpositions, facial skin cancers, tear drainage issues, orbital tumors, and thyroid eye disease. She treats children and adults. Her research interests include the effects of eyelid surgery on ocular surface diseases and visual function, oculoplastic surgical techniques, and mechanism underlying orbital disease. Dr. Rajaii received her MD and PhD in neuroscience degrees from Johns Hopkins University School of Medicine. She completed an internship in internal medicine at Mercy Medical Center prior to completing her ophthalmology residency at the Wilmer Eye Institute. She also completed her fellowship in ophthalmic, plastic, orbital, and facial cosmetic surgery at the University of Michigan prior to joining the Wilmer faculty. I am honored and pleased to introduce Dr. Rajaii.
So thank you to Brian and RPB for the opportunity to present today, as well as for funding my research. I know this isn't a CME talk, but I do think because these disclosures are relevant to thyroid eye disease, that it is important to highlight for the audience that I have worked with companies making thyroid eye disease drugs before, as well as having research support from other companies developing thyroid eye disease therapies. So today we're going to be talking about thyroid eye disease and describing clinical characteristics of TED, the traditional treatment paradigm for TED, and then introducing novel and investigational treatments for thyroid eye disease. So we'll start out discussing clinical characteristics. Regarding epidemiology, thyroid eye disease is more common in women than in men, with an incidence of about 16 per 100,000 women and 2.9 per 100,000 men. We can see there's a bimodal distribution with onset seen in middle age and then at around the 60s. Usually there are more severe presentations seen at greater than 65 years of age with later presentation, and in men, the presentation is usually more severe. The incidence in non-hyperthyroid patients is around 8 to 18%, and there's a calculated prevalence of about 0.25%. In patients with Graves' thyroid disease, the prevalence of thyroid eye disease is about 35 to 42%. However, thyroid eye disease can occur with patients with or without thyroid disease. And just to describe the relationship with thyroid disease in general, we do see that it is most commonly seen with hyperthyroidism. So about 90% of patients in this study who had Graves' eye disease were hyperthyroid, with only about 0.8% being hypothyroid. Can also be seen with Hashimoto's thyroiditis. And then about 6% of patients may present and be euthyroid or have normal thyroid function at the time of presentation. This graph, I think, is a nice chronology to describe sort of the onset of thyroid disease and the onset of thyroid eye disease. So we can see that about 40% of patients will have the onset of thyroid disease at the same time of their eye disease onset. However, about 40% will have it at the time of hyperthyroidism, and then about 20% will have it before having any thyroid disease. Sorry, I think I misspoke. So 40% at the time of diagnosis, 40% after diagnosis of thyroid disease, and about 20% before. And these may account for what we saw on the previous slide, the euthyroid patients presenting with thyroid eye disease, such that they just have not really manifested their thyroid dysfunction yet. Risk factors for disease are female sex, which is about 2.5 times risk factor, and then smoking. Smoking is really the main modifiable risk factor, and it's really the current number of cigarettes rather than lifetime consumption. So this can be a big motivating factor to help patients stop smoking, because smoking is associated with more severe disease onset, increased likelihood of progression, and increased likelihood of recurrence once the disease has died down, as we'll see. There are also questionable data regarding possible secondhand smoke exposure being a risk factor, but that hasn't really been shown definitively. But it has been shown that there is more childhood thyroid orbitopathy in children in societies with higher smoking rate. In terms of clinical findings, eyelid retraction is the most common at greater than 90%. So we can see some eyelid retraction in this patient here. Usually that manifests as being able to see sort of the whole cornea or the whole iris colored part of the eye, or even some of the whites of the eyes around that, representing retracted eyelids. There can be eyelid swelling or edema, conjunctival injection or redness as seen here, and chemosis, which is actually swelling under the conjunctiva. Some patients will describe that as looking like there are blisters in the corners of their eyes. Exophthalmos or bulging of the eyes is seen in about 60% of patients. There can be motility restriction or misalignment of the eyes in about 40% of patients. This is very disabling and is a cause of double vision. We can see in this photograph here, this patient has a hypotropia, or their right eye is sort of fixed in down gaze, and they have trouble moving the eye when they look in various gaze directions, and that's all a result of thyroid eye disease. And then optic neuropathy can also occur. This is one possible cause of blindness in this disease at about 10% of patients. Also, just exposure from eyelid retraction, proptosis, and dryness is another major cause for blindness in these patients historically. Well, now we're able to treat the corneal and ocular surface better, so it's less commonly a cause of blindness. In terms of imaging, we often obtain CT scans in patients. This is helpful for us both to be able to image the anatomy and see sort of the bony anatomy in case we do want to undergo surgical therapy in the future, but also for diagnosis, the presence of tendon sparing enlargement of the extraocular muscles, which you can see here, and then also in this coronal view is characteristic of thyroid eye disease. There's also a characteristic pattern where most commonly the inferior rectus is involved, then the medial rectus, then the superior rectus, and lastly, the lateral rectus. So traditionally, we did more CT scans. People are moving towards doing more MRIs, possibly more for research. I think people are looking at this as possible way to define whether there's activity or not, and maybe whether that may help us predict who would be more likely to respond to therapy. Associated findings. So thyroid eye disease is part of a systemic disease as witnessed by the thyroid dysfunction, but there can also be pretibial myxedema, which is finding on the skin of the shins, and then acropachy. And these are both risk factors for severe disease. The clinical course is that generally thyroid eye disease is a self-limiting disease. There is an active phase that lasts 1 year on average in non-smokers and 2 to 3 years in smokers. And after this active phase, patients enter what we call a stable or quiescent phase. That's sort of demonstrated here on this graph. So there's activity, which then recedes into a quiescent phase. During the active phase, the disease course is changing. So all of the characteristics that we discussed in terms of bulging, eyelid retraction, swelling, redness, those are all variable and will vary during this active phase of disease. And then there's a 5 to 10% risk of reactivation over a patient's lifetime. And as I mentioned before, that's higher in smokers. So our traditional thyroid eye disease treatment algorithm or paradigm is based on, first and foremost, doing what we can to try to alter disease progression. Endocrine management, restoring euthyroidism is very important. Smoking cessation is very important. And then local measures as can be done really to manage sort of ocular surface disease. And then really for all but the mildest cases, referring to specialist centers where there's more multidisciplinary care and perhaps more experienced care. Generally, all patients we sort of stratify to mild, moderate to severe, or sight-threatening disease. These characterizations were defined by UGOGO, or the European Group on Graves' Orbitopathy, as demonstrated on this slide. I'm not going to read this exactly, but sight-threatening Graves' orbitopathy is those who have potentially blinding disease due to either optic neuropathy or corneal breakdown. And then moderate to severe versus mild disease, they do have some guidelines in terms of the amount of lid retraction or the amount of bulging of the eyes. However, what I think is really most important is that it's patients without sight-threatening disease whose disease has a sufficient impact on daily life to justify the risks of treatment. Whereas we would consider those mild, those who really only have a minor impact on their daily life, not sufficient to justify treatment. And, so some of this does really involve a personalized approach in which we really discuss with the patients how much they're affected and impacted by their symptoms and whether the risks of treatment outweigh the benefits. So for patients with mild disease, generally we are doing local measures in terms of protection of the ocular surface and really aggressive, if needed, ocular surface treatment, and then waiting to see what happens to the disease. The reason for this is in a natural history study from the 90s, about 60 patients with mild orbitopathy were not treated and observed for 1 year. And during that 1 year period, about 22% improved substantially, 42% had minor improvement, and another 22% did not change. So really the majority of patients either improved or were stable, and it was really 13.5% who deteriorated progressively. And without being able to identify who these people, patients who will deteriorate progressively are, it may be difficult to justify the risks of treatment. So generally, as I said, we will do watchful waiting of patients, doing what we can for sort of comfort. And then once stability and inactivity have been reached, we would consider rehabilitative treatment. For those, I'm going to skip over here to sight-threatening disease. Generally, the paradigm has been to treat with IV glucocorticoids for optic nerve protection and an attempt at decreasing inflammation sort of in the acute phase. And then if there's no response, really referring or undergoing prompt surgical decompression in order to save or preserve what visions the patients have. And then after that, going based on their activity, sort of if further surgery is needed or further immunosuppression or steroids was needed. Now, for moderate to severe patients, there is another decision point in which we stratified patients based on whether they have active disease or not. And active disease is defined in various different ways. Now, based on, I think what's in the literature, what is being used most often is this clinical activity score, which was developed by Moritz in 1997. It was really originally devised as a 10-point scale, which did incorporate some measure of how things were changing or whether things were stable in the disease. But now what's used is a 7-point scale, which is really a combination of patient-reported symptoms and then signs that are seen on physician's exam. And these include things like spontaneous retrobulbar pain, pain on attempted up or down gaze, redness of the eyelids, redness of the conjunctiva, swelling of the eyelids, inflammation of the caruncle, and conjunctival edema. And so active disease or patients would be those who were targeted for therapy or immunosuppression, and patients with inactive disease would be considered for surgery. Traditionally, the mainstay of treatment was IV glucocorticoids, and the European Group on Graves' orbitopathy had recommended dosing, as shown here. That was about a 12-week course of infusions. The contraindications mostly had to do with possible liver dysfunction that could result from use of high-dose steroids. So pre-existing liver dysfunction or hepatitis were contraindications, as well as hypertension, unstable diabetes, or cardiovascular disease. Another more traditional treatment was orbital radiation. However, there was this prospective randomized controlled trial that of 42 patients who were treated in one orbit with external beam therapy and sham therapy on the other side. And after 6 months, those treatments were reversed, and there were no clinically or statistically significant differences noted at 6 months. And then at 12 months, there were slight improvements in the muscle volume and bulging seen. So based on these results, a lot of people stopped doing radiotherapy, except for patients who had really prominent muscle involving disease. And then since 2020, the FDA has approved teprotumumab, which was originally studied in patients with moderate to severe active disease, although the FDA approval was for patients with any form of thyroid eye disease. And so now we're going to move into sort of the emerging treatments or more novel treatments for thyroid eye disease. Before we do that, I thought it would be good to try to take a look at a cell and get an idea of what's going on in the orbit to cause thyroid eye disease. So the orbital fibroblast is sort of the key player behind the eye that's resulting in this disease. These cells display TSH or thyroid stimulating hormone receptors, and the main antibody that's thought to be causing the disease are thyroid stimulating antibodies that interact with this receptor. It's thought that in a complex with the IGF-1 receptor, this antibody activates both of these receptors and causes changes to the cell. The orbital fibroblast becomes activated and produces cytokines that can further activate inflammation and further perpetuate the immune response, but also undergoes changes such as secreting more hyaluronic acid, glycosaminoglycans, undergoing myofibroblast differentiation, really responsible for the fibrotic changes that are seen, and then differentiation to adipocytes, thereby expanding the volume. And this is these are the processes that I study in my lab. So teprotumumab is a monoclonal human antibody that inhibits insulin-like growth factor 1 receptor, the IGF-1 receptor, as seen over here. And it's an infusion that's given every 3 weeks for a total of 8 infusions. It's only currently available in the United States and in Brazil. And its FDA approval was really based on the promising data from the OPTIC clinical trial. And here we see one of the patients who was treated in the trial, their baseline, and then how they appeared 24 weeks after their initial dose. 41 patients were treated and 42 patients were given placebo. And about 83% of the patients treated, compared to only 10% of those with placebo, had a response in terms of the bulging of the eyes. And that was really the primary outcome. And then there were other endpoints, including responses in terms of improvement in double vision and improved changes in quality of life, all of which were positive. As I mentioned before, we're starting to look at MRIs now, maybe more for research purposes, and we can see from MRIs from the OPTIC trial that the inflammation and enlargement of the inferior rectus muscle in this patient and inflammation in the fat subsided after the 24-week point after the initial dose. So initially, as I said, this was really studied in randomized controlled trials for patients with moderate to severe active disease. Since its FDA approval, it has been used in other contexts, including for patients with sight-threatening disease. So this was a patient seen in the University of Michigan who had pretty severe sight-threatening disease. We can see the enlarged muscles in the orbit, which were impacting the optic nerve, which is kind of getting crushed back here, probably from all that extra volume. And after treatment with teprotumumab, the patient improved both in terms of their appearance, their extraocular muscle size, and their visual function. Like all treatments, though, there are side effects. So most commonly, muscle spasms and nausea are seen in patients. Less commonly, but also of concern, are hyperglycemia and hearing impairment. However, targeting the IGF-1 receptor has been seen as a really promising approach and effective approach for thyroid eye disease. So there are numerous other IGF-1 receptor antagonists that are currently in clinical trials, as shown here. These are the phase of development. They're administered in different manners, and including an oral administration, an oral drug, small molecule inhibitor that is in trials right now. So at the very least, we'll likely end up having more than one IGF-1 receptor antagonist available for this drug. But as we shall see, I think the success of teprotumumab and the promise for treating patients with thyroid eye disease has opened a lot of interest, or sparked a lot of interest into thyroid eye disease. So there are also many other drugs in development, such as sartralizumab. So this is being developed by Roche. This is a humanized anti-IL-6 receptor antibody. It's currently labeled for use in NMO spectrum disorder. And this is currently in clinical trials, so we don't have much data about it for thyroid eye disease, but what we do have data for is tocilizumab, which is a similar anti-IL-6 receptor antibody, not labeled for use for thyroid eye disease, but has been used off-label. And case reports had shown improvements in patients in terms of clinical activity score, decreased antibody levels, decreased inflammation. And Perez Moreras et al. In Spain actually did a randomized clinical trial of 32 steroid-resistant patients, and they did show an improvement in the clinical activity score in 93% of tocilizumab patients, compared to only about 60% of controls at the 16-week time point, though that wasn't seen at the later time points. And then they did see a decrease in the bulging of the eyes in patients treated with tocilizumab versus those treated with control. So currently this is used in Europe, again, where teprotumumab is not available. And as I said, sartrilizumab is now in development. Another drug that was being looked at is secukinumab, which is a human anti-IL-17A agent currently labeled for psoriasis. This clinical trial was underway last year. However, it was terminated last July after analysis of masked patient data showed low probability of meeting the primary efficacy endpoint. There were no safety concerns identified, but this will not be further developed for thyroid eye disease. And then belimumab is a human anti-B lymphocyte stimulator currently labeled for use in lupus. And this was studied in Europe in a single-blinded randomized control trial comparing belimumab to methylprednisolone IV. The results of this were presented in 2021, and they treated 27 patients total. They were treated at day 0, 14, 28, and then every 4 weeks. The first dose was given with methylprednisolone, and then this was compared to just methylprednisolone dosing weekly for 6 weeks, and then a decreased dose. And generally, the clinical activity score was higher in patients treated with belimumab than those treated with methylprednisolone after 12 weeks, although inactive disease was achieved with both treatments, and proptosis improved with both, though more significantly with methylprednisolone. The conclusion was that this is as effective as methylprednisolone for thyroid eye disease, but maybe less effective and perhaps a good alternative in steroid-resistant patients or for those who can't receive steroids. Again, and everywhere in the world except for the United States and Brazil, there's still no specifically labeled agents. So this would be quite appropriate for use in other nations. And then other approaches that aren't targeting specific cytokines or immunogens in the body include targeting what's called the FcRn, or the neonatal fragment crystallizable receptor. So all antibodies have an Fc portion that is recognized by this FcRn, which actually promotes the immunoglobulin's half-life, rescues immunoglobulins from lysosomal degradation normally. So antibodies that are in circulation will be taken up by cells, and in the presence of the FcRn, they're rescued from being degraded. However, when agents such as batoclimab and other things that target this FcRn are present, the interaction between the FcRn and the antibodies is blocked, therefore antibodies will be degraded and their half-life will be decreased.
Dr. Rajaii, you should wrap up in the next 2 minutes, please.
Of course. And it has been shown that administration of this drug does decrease total antibody levels and thyroid stimulating antibody levels in patients with thyroid eye disease. There was a phase 2A study that had promising initial response, but it was halted because patients had increased serum cholesterol. However, they have moved on to phase 3 studies, which are underway right now. And there are numerous other anti-FcRn agents that are in clinical trials, specifically 2 that are for thyroid eye disease specifically. And these are exciting because they may also have an impact on thyroid disease. And then one last investigational agent to discuss, just because it's the only thing that's actually being looked at for an local retrobulbar or subtenons around the eye treatment for this disease, as opposed to the systemic treatments we've already discussed, is aflibercept, which is an anti-VEGF agent. This is being looked at as a result of demonstrated increased VEGF expression in the thyroid eye disease orbit. And this is going to be looking at patients with intermediate clinical activity scores. So we've sort of gone through the traditional treatment algorithm and how teprotumumab, I think, has come on the scene and generated a lot more interest in treatment of thyroid eye disease. And I think the future for our thyroid eye disease patients and for those of us who treat thyroid eye disease is bright. As with all these new agents in development, we should be adding to our armamentarium in terms of what we can offer to patients. Thank you, guys.
Thank you very much, Dr. Raj. That was very, very in-depth, and we really appreciate that. Our second speaker now will be Mrs. Justine Peters, who is a working professional with TED and has many years with the condition. So I'll turn it over to her so that she can talk to us about her experience with thyroid eye disease.
Okay, thank you. Briefly, my story started in 2009 with my diagnosis of Graves. Back in 2009, I went under radioactive iodine after the anti-thyroid drugs did not work for me. Very shortly, knowing what I know now, I think I would have given them a better chance to work longer, but I can't change the radioactive iodine, which was done in December of 2009. And then I went hypothyroid. So I'm on Synthroid, but my Graves antibodies are still active, the TSI, and they've never, as long as I've been monitoring them since 2015, they reached a lower level to normal, but never completely in remission. And then in 2017, I'm trying to think. 2015, my eyes started swelling, but at the time I did not know I had the bags and some of the eyelid drooping. So I went to a plastic surgeon to do the upper and lower blepharoplasty in July. Oh, so actually it's 9 years now. So July of 2015, I did that. And then it really fired up in the end of 2016 into 17 with the light to sensitivity, some eye bulging, not a lot. Looking at me, people would have to look really close or compare pictures to actually see the physical symptoms. I had more of, I suffer from migraines in general, but I had more ocular pain with the muscles very, very badly. And, my first ocular surgeon told me to just let it burn out. Then I got diagnosed, and this is where the pretibial mixed edema comes in, which is even more rare. I started with the feet swelling and mild rash on my shins. 23 doctors later, I got diagnosed by a dermatologist at Mount Sinai in New York City that I'm actually still in communication with it. So May of 2017, I started Rituxan, and I did 1,000 milligrams every 6 months. It did help my eyes temporarily, but I did it until 2019. My feet started coming down, the eyes got a little bit better, but then I developed double vision, the peripheral double vision, which I still have now. I did Tepezza when it got approved, COVID hit, and then I started Tepezza in May of 2020, did the 8 rounds into the end of 2020, early 21, I believe. And then, no, I'm sorry, 20, I did it all in 2020. And then about 8 months later, it started firing back up, and my double vision and the pain came back. But then this time, in the summer of July of 2021-ish, somewhere in there, the double vision got worse and came on in my front. So I was seeing 2 of things at some point. The eye irritation, the grittiness, all that came. Not really too much eye bulging. And then when I got approved for a second round of Tepezza, and I started that in 2022 in September. So I did September, October, November, December into January of 2022. And the front double vision went away, but the migraines were so bad, a side effect for me from the Tepezza, that I had to stop. So I'm at a point where now I go see a neurologist, ophthalmologist, ocular surgeon in Saratoga Springs, New York, which is 2 hours one way from my house. I've been with him since fall of 2017, and I was doing okay. And then this past year, I've been bouncing between my regular neurologist for the migraines and Dr. Charles Riemann, who's my eye specialist. Went through blood work. I went through testing for myasthenia gravis, MRIs, CAT scans, and my last visit was in June. And we're going to try Tepezza again. According to him, he doesn't think the disease is active, but my neurologist thinks it is. And finally with a good endocrinologist that actually go see next week, my levels are pretty much in check, but I have to get the TSI checked. It's just a debilitating disease, like mentally, physically, emotionally. For me, after I have a 4 mm decrease from the Tepezza in my right eye and 3 in my left, and my dermatologist from Mount Sinai said that the Tepezza, I'm not sure which receptors, medical people would know that, it works with, put my pretibial myxedema in total remission in 2021. Yes, in 2021. Total remission ever since then, and I have no recurrence of that. I believe my thyroid eye disease has stabilized at this point, but I do get the light sensitivity and the peripheral double vision. So I joined the tedcommunity.org because right now that's the only support group for a one-stop shop website for support, art therapy, Amgen. I was at the Amgen seminar at the end of May, right? May 22nd to the 24th. Lots of information about patient support, emotional support, free services for people with thyroid eye disease, if they're so bad that they can't drive, providing free transportation to and from a doctor. Some caregivers are very supportive, some aren't. That's one thing. It's a very hard hormonal thing to deal with in general. At your level and getting to a point where you're functional.
Well, thank you very much for that very informative share that you have shared with us, your experience. I do see that we do not have any questions in our board right now. How about anybody have any questions? Or what I can do is I'll start with my own question. And it would be for both of you. More importantly, when we think of thyroid eye disease, it's very important to think about the multidisciplinary approach to this disease. And so I'd like to maybe ask you both in terms of your experience with, the conversations with the endocrinologist, the ophthalmologist, and the journey that you had relative to ultimately getting treatment, or in Dr. Rajai's case, deciding to treat a patient with Tepezza. Can you both elaborate a little bit on the journey that you both had to then get the treatment and follow-up for that matter? I'll pass it to Dr. Rajaii.
Okay, thank you. So I think certainly as has been highlighted, it is really multidisciplinary care of patients with at least, it sort of depends where you are, but certainly the ophthalmologists, such as myself, are not managing the thyroid disease. So there's at least an endocrinologist. Sometimes primary care doctors are managing patients' thyroid disease. And then on the ophthalmology side, usually at least one ophthalmologist, such as myself as an oculoplastic surgeon, but often if patients do have strabismus and double vision, there's also a strabismus specialist involved. So there's always a multi-doctor team, all need to communicate well with each other. And I think, for patients, it's very frustrating. The main goal, one of the first goals, as I said, and as was highlighted on that algorithm slide, is to restore euthyroidism. And how to do that, is not straightforward. There are some patients who are have much more difficulty in getting their thyroid levels stabilized compared to others. And from what I've seen in the data, there's not one specific preferred method to control thyroid levels. And generally, as Justine said, she started out with anti-thyroid drugs, which are generally viewed pretty favorably. I know some oculoplastic surgeons who are more in favor, I think, of thyroidectomy, even though I haven't found data that shows that that's better. But what it might do is maybe make thyroid disease easier to control because you've taken out the patient's own thyroid, so there's less level adjustment. But my heart really goes out to patients, because some people will come in with, different Synthroid, for example, doses. They take a different dose every day or like 3 days out of the week. And figuring that out, which is really key to helping control the disease, is not really straightforward at all. And it's a lot of trial and error, right? You adjust your doses, you get your levels checked in like 3 months, and then you do a little more titration. And I think that just adds to what may already be frustrating process of let's wait and see what happens with the disease.
Right. And so that personalized approach, that each case is unique and individualized. But yes, in knowing that there are many doctors involved in looking at the, balancing the benefits versus the risk. I'll pass it to you, Justine. Any comments relative to the many doctors that you had to see and how they were communicating? And lastly, how you got to the point of deciding to take the treatment based on the benefits and comparing the risks?
It's I think, okay, so my experience with endocrinologists, I avoided them for like 7 years. And then my primary doctor said, she left the practice. I was with her for years. And then I got referred to another primary. She referred me to my current endo, and I waited 7 months to get into him. He looked at me as a whole person instead of, okay, well, here's some medicine. This has been my experience. Yes, the wait and see is very frustrating, but would I change it? It was worth 7 months of waiting. So I personally keep myself in touch with all my doctors. I think the more educated the patient is, the more the doctors will stop for 5 minutes and actually listen to them. I was lucky. I only went to eye doctor wise, maybe the third one was Dr. Riemann, and I stayed with him ever since. The pretibial mixed edema, it took me 23 doctors to get a diagnosis. And that was worse than, it's all tied in because your thyroid affects every cell in your body. And once one thing is eliminated, something else fires off. And that's the frustrating part, that the doctors don't actually talk, in my experience. Like when I went to see Dr. Riemann, I was telling him my whole story. He goes, can you wait another 15 minutes? I want to talk to you. I'll be right back. Well, I had all the data he needed, and to prove to my dermatologist that the TSI was tied into the inflammation, I had like, by that time, 5 years of records. And I'm like, this is when I felt worse. This is when I was at my dark time at the top of the disease. And then they actually agreed with me. So I keep my doctors informed. I educated myself. I went to a functional doctor, and he's like, what is a TRAB? What is TSI? And I'm like, oh, forget it. I'll just keep going. So I'm lucky as to where I'm stable right now, but getting there, I was on 100, and getting name brand drugs versus the generic, for me, made a big difference. And that's the thing, like, there's no, like, appendix fires up, oh, you take it out. With thyroid, it's not everybody's the same, and patients do get frustrated from going doctor to doctor. And that's why I do these webinars and stuff, because the more information I gather, the more I can pass on to other people.
Right.
That's the thing, is that you go from bouncing from one to one, or they just fluff you off. Like, no, you need a doctor to it is multi,
Right.
specialists that you have to go through, but it's also lifestyle. I don't drink anymore. I try to get my inflammation under control where I eat more protein. I don't eat processed food. That all comes into play. For your general, like if I have a drink, even one or two, my eyes are like the next day. And I'm like, is this worth it for me? No, it's not. Just overall, I don't feel good, and then with autoimmune brings like other problems, like IBS or stomach issues. At least for me, it affected my GI system.
Yeah.
So I have like more than just the eye people. I have, yeah. So, and the older you get, I always tell people, go for your eye exams, go for your, like I see an optometrist for my glasses. So this is the first year that my prescription hasn't changed and they want to put prisms in. I'm like, no, I just want to keep it simple. That's just me. But everybody is so different that, it's frustrating. I had heart valve. I was on 175. I'm on the name brand Synthroid. And I was having heart palpitations. My current endo brought me down to 150. Boom, heart palpitations gone. I didn't even think of that because I had been on the dose for so long. So, the doctor's communication is very important, but in this day and age, in my experience, it's really not there. So the more prep the patients are, I think the more the doctors will listen and look at more scans and look at more stuff and blood tests and all that, ultrasounds, whatever it is. And, then that helps the patient be more successful, in the TED community and learning about Amgen. Big pharma is not, most of it is for money, but Amgen's, for my experience for Tepezza, has not been that way. And Tepezza changed my life because my doctor said, I don't know what further damage could be. Your double vision could get worse if I do surgery. And I'm like, oh no. And after seeing what happens during that surgery, I'm like, I'll do the Tepezza. And it did help improve overall my life in both ways with the Graves' dermopathy and the eye disease. So.
Yeah, thank you, Justine. I think you elevated very important points here. So number one is our own education, meaning from all stakeholders, as we were talking earlier. So from the patient perspective, being educated, and that this is actually this activity right now and all the initiatives we have to promote education, awareness, and advocacy for oneself. And at the same time, with Dr. Rajaii and me being an endocrinologist, it is an important concept to discuss that multidisciplinary approach and being able to have, your doctors talk amongst themselves, but then knowing that the patient at the center has all that information. And I commend you for having your binder or bringing your records and being an advocate for yourself, and relative to even balancing the benefits versus the risks of the different treatments that Dr. Rajaii discussed. So I'll pass it back to you, Fatemeh, if you want to add anything else to that.
No, I just did want to remark though that as Justine mentioned, her skin changes did get better with teprotumumab. And although a lot of the studies and a lot of the data we have for teprotumumab and the forthcoming studies are focused on eye disease, I'm also excited to see how it impacts everything else. Because as Justine mentioned, as we know, the thyroid does affect everything in the body, and Graves' disease affects everything in the body. So it'll be interesting to see how the rest of the body is also impacted, not just my little corner of the body.
Oh, I'm sorry. I do have two case studies that were done for me personally in the dermatology, the research, the AMA, where you guys do all that, it's only like doctor reports. So there is definitely a case study done. It was done for other clinical use.
Yeah, definitely. And, as more people receive the drug, more of that will hopefully be forthcoming.
And I'd like to emphasize, so because I'm representing Amgen, so we always talk specific to the label. So the treatment of pretibial mixed edema is not on the label right now. But at the same time, as you both discussed, there's the holistic and the whole body effects of thyroid eye disease, as well as the medication. And then there's a localized effect and kind of what our science discusses. But it's very important, like Fatemeh was saying, it's like as more people use it, we are able to then understand all the different benefits and then bring that information to the FDA to continue to expand the package insert and the label. And on that note, the label has been updated to then open it up to not just the short duration, but longer duration patients with thyroid eye disease, but also cautions the importance of, baseline monitoring for potential adverse events, including that of hyperglycemia and hearing impairment. And so I'll pass it to you, Dr. Rajaii, if you wanted to comment a little bit on the potential adverse events and how we balance the benefit relative to the risk and how important it is to educate ourselves and that communication between the doctor and the patient so that if you are any of these potential things happen, you have a baseline assessment and you are able to reach your doctor sooner rather than later. Passing it over to you, Dr. Rajaii.
Yeah, so we've certainly, based on some of the case reports and things that have come out in the literature and even studies in the literature, I think almost everybody who's prescribing teprotumumab has started doing pre-treatment audiology just to get at least baseline hearing, really with hearing loss being a main concern. Although I think in most cases it has been shown to be reversible. At least at my center, we had one patient who ended up needing a cochlear implant, so it was not reversible in that case. So we may be a little more conservative than at other centers. And there is, as these things emerge, there's more data available about them. So it does look like there's a newer protocol sort of that looked at audiology and then changes even in patients with pre-existing hearing loss. And in most patients, they did fine, or if they developed anything, it improved. But that's not my decision to make, honestly. So I tell patients about that and they can decide. And for some patients, they're like, oh, do I have to choose between my hearing and my vision? And it's kind of a heartbreaking conversation to have, which is one reason why I think it's good that there are other new emerging therapies with different mechanisms, which may, for patients who have pre-existing hearing loss or who are more concerned about their hearing, may be good options for them instead. And then for hyperglycemia, generally, most of my patients have endocrinologists. So, and those who are diabetics, we do communicate, so they'll know to help manage if they're on insulin, just manage their blood sugar or be more attentive to it while they're on treatment.
Exactly. So to be more specifically, there is a potential that you might have hyperglycemia before, a pre-existing condition of diabetes, as it is a common disease nowadays. But that is not a contraindication for the treatment with Tepezza. But therefore, by knowing that this can happen, you become more aware and you monitor these changes. And or in that matter, if you start feeling thirsty or feeling like you're urinating a lot, it's very important to communicate with your doctor sooner rather than later. So thank you for that. So how about any other final remarks or any other comments that you would like to add that you think would be important to share with our community that is listening to this webinar? Any closing remarks, Dr. Rajaii, and then pass it to Mrs. Peters?
Yeah, I think, as I said, this is really an exciting time to be treating thyroid eye disease as more and more options. I mean, first of all, we have one option, teprotumumab, which never existed, an actual drug labeled for thyroid eye disease. I do still think, we're just at the beginning of this. So for all of these, for everything, for teprotumumab, for anything else that does come along, I don't think we'll really know, maybe in the next 10 years, we can answer what's really going on with the drug treatment. Justine did discuss needing to be on for a second course of drug. So most patients don't need that, but there are patients who need that. And then the question is, are we actually changing their disease or stopping the disease or prolonging the course of the disease? Or perhaps patients would need to be treated long-term at lower frequency. So there's still a lot of questions to be asked, and it's certainly an exciting time to be someone treating it. But I think it's also the dawn of a new age for patients, and it is a difficult disease to have. But now we at least have some targeted therapy available, and I think we'll only have more in the next few years.
Thank you. How about you, Justine? Any closing remarks?
Oh, sorry.
We can see.
No, I think if just getting the information out to other doctors about the multidisciplinary approach, and that's what the TED community.org group was trying to figure out, how to get the information out to patients and doctors, like, so you can have that relationship with your providers. So I'm status quo myself. If I come across people that don't know what to do, I try and tell them to be a self-advocate for themselves. But I think once the support group for the thyroid eye disease, we're not going to, on Facebook, there's not going to be that many restrictions as far as posting links and things like that. So that's what I'm going to get more clarification about, and inviting providers to come in. But that I have to check about, or even having Amgen come into the group, because we've done so much work with them. So when I get that and set it up, I can let you know, I guess, that support's going to be available to people, which is, I feel, valuable thing to have when there's really no place that encompasses all the information in one place. So that's why we're really, we can set our own restrictions for the Facebook group and just provide, if anyone has a question or needs support in something, we can try and direct them to what kind of doctor to go to, because it does encompass the eyes, the skin, the thyroid problem. Like, we're not just going to be limited to just the eyes. So
Well, I want to draw this session to a close. We're out of time.
Okay.
Unfortunately. It's been a great discussion, but I want to thank Amgen for the sponsorship of this Lunch and Learn on thyroid eye disease. I want to thank our moderator, Margarita Ochoa-Maya, for a great job of leading the discussion, and our two speakers, Dr. Rajaii, for really giving us a great overview and a glimpse of some of the emerging therapies, which is very exciting. And to Justine Peters for really giving us a frontline account of, that it's important to remember that these diseases, eye diseases, affect real people. And so thank you so much for sharing your story and giving us that important perspective. So thank you all for your participation. Thank you very much.